Hello, 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 ladies and gentlemen. Hello. This is the 2-minute, 10-minute lecture on substance abuse. And again, I thank you for your time and attention to this very sensitive and emotional subject. So, we need to remember that this is a disorder, just like any other disorder. It is a disease process. So, diagnostic criteria of substance abuse disorders. So, when medications with addictive properties are prescribed for an individual, it is not uncommon for the individual to develop a physical dependence. So, please know the difference between physical dependence and tolerance, and then actual addiction, without engaging in the maladaptive behaviors that define an SUD. Because someone with physical dependence, they will um, they will develop some withdrawal symptoms only because the body wants the medication. If the body did not need the medication and this person did not have a maladaptive disorder, an addiction property, um, personality, they wouldn't go looking for the medication. So, when medications with addictive properties are prescribed for an individual, it is not uncommon for the individual to develop a physical dependence without engaging in the maladaptive behaviors that will define an SUD. So, for example, a patient with cancer will be prescribed an opiate for pain, and they may develop a physical dependence even when the opiates are used as they are prescribed. So, epidemiology. The central nervous system stimulants will include cocaine, methamphetamine, and then prescription stimulants. And will all act on the brain in similar ways. Stimulant will affect the stimulant effect of these drugs, yes, I'll be right there, include increased alertness, wakefulness, and energy, and then physical side effects of rapid or irregular heart rate, increased blood pressure, and then an elevated body temperature. So, in thinking about genetics, genetics will only influence, ladies and gentlemen, the risk for an SUD. Research will support a genetic component for nicotine, alcohol, cocaine, opioids, and cannabis use disorders. So, an individual with a genetic predisposition for an alcohol use disorder or another SUD cannot develop a disorder if the person does not drink alcohol or use these drugs. So the interaction of biology and environment will determine whether an individual develops an SUD. But again, it is also just like diabetes. So if one of my parents has diabetes, yes, there is a risk that I will develop diabetes because that predisposition is there. But if I do what I'm supposed to do and take care of myself, then I may never develop diabetes. So, psychological risk factors. For example, a person who uses cocaine and other stimulants, such as methamphetamine, will often experience an inflated sense of self, and we call this grandiose behavior. And they will describe feeling energized with increased alertness and then ready to take on anything. People who use heroin or marijuana will often feel very relaxed and mellow after the initial euphoria. So, alcohol and other drugs are often portrayed as enhancing the enjoyment of social interactions, meaning that if I am shy or if I am introverted, especially in social settings, if I have a glass of wine, if I have a couple of beers, then I'm able to relax and be more extroverted. So, how psychoactive drugs will affect the brain, because we have to remember, ladies and gentlemen, that we are dealing with a sick brain. This is a sick brain. So, to understand how an SUD can be considered a disease, the nurse must appreciate the intricate communication system that is going on inside the brain. So, to function normally, the brain must maintain a careful balance of neurotransmitters. These small molecules will carry messages between the nerve cells, we call these neurons, to help regulate the body's function and behavior. So psychoactive drugs are chemicals that in one way or another are going to tap into this communication system and then disrupt the way the neurons will normally send, receive, and process information. And this, ladies and gentlemen, is the neurochemistry of the brain. So please remember that using alcohol, taking an SUD, or a substance, excuse me, is going to affect the way the brain works. So in doing so, we are dealing with a sick brain. So when you please remember, when you are talking with your patient, you are not talking to a healthy individual, with a healthy brain. You may be talking to a healthy individual physically, but they do have a sick brain. So now let's think about withdrawal symptoms. Almost all people with an AUD who have been chronic drinkers will experience some level of withdrawal symptomology if they suddenly stop drinking or if they, on their own, significantly decrease the amount of alcohol that they will consume. So the clinical presentation can range from tremors, anxiety, tachycardia, and irritability to life-threatening grand mal seizures, and then the medical emergency of delirium tremens. And all of this can include confusion, hallucinations, autonomic instability, and then if it is not treated appropriately or if the patient does not seek treatment, they may pass away, so death. Treatment for alcohol. Some patients will need to be hospitalized in a facility that will specialize in detoxification and can provide close monitoring of vital signs and assessment of withdrawal symptoms because remember, this patient is definitely going to need to be monitored. They're going to be needed to be assessed frequently. Excuse me. Alcoholics Anonymous will play a major role in the treatment of AUDs nationwide, and this program has proven to be an extremely effective treatment approach. Currently, there are only 3 medications that are approved by the U.S. Food and Drug Administration for the treatment of AUDs, and that is Antabuse, Revia, Endopade, and then Camprol. Ladies and gentlemen, please know these medications. Antabuse was the first medication approved for the treatment of AUD and is used to discourage drinking by inhibiting acetaldehyde dehydrogenase. So the patient will become very ill from drinking alcohol. So they have this adverse reaction to the acetaldehyde. Naltrexone will work by blocking in the brain the high that people experience when they drink or take drugs such as heroin or cocaine. So barbiturates. Barbiturates are still used as anticonvulsants and anesthetic agents and have almost entirely been replaced by the benzos as legitimate medications used in the treatment of anxiety. So because of the potential for barbiturates to cause respiratory depression, they are incredibly dangerous in cases of overdose. So treatment for heroin, there are some chronic users that may not respond to Suboxone and may require maintenance treatment with methadone. Methadone has been used effectively for more than 30 years to treat opiate use disorders. It has a controlled release effect that will greatly reduce the addiction risk by blocking the action of the opiate, as well as reducing withdrawal symptoms and then drug cravings. And then Revia and Vivitrol will prevent substance users from feeling the effects of the drug. So, cocaine. The increased energy and mental alertness and the feelings of grandiose and exhilaration and acute cocaine intoxication can quickly turn to irritability, agitation, and then restlessness. The euphoric state is going to be replaced in short order by withdrawal, and this is going to be characterized by anxiety, paranoia, depression, and then suicidality. So these contrasting mood states will signal the brain to use more because the brain doesn't feel good anymore. The body is not really even feeling good either. So what the brain is saying is give me more, give me more, give me more. So the patient is going to seek out more of the drug cocaine in order to make the brain happy because the brain wants more. So, cravings for the drug cocaine are a cardinal feature of cocaine disorders and are significant because of the potential to trigger use and then relapse because we cope, right? As humans, we have our coping mechanisms, and in times of stress or when we are uncomfortable, we go back to that coping mechanism, whether is it a positive or whether it's a negative. So, people who cope by going to the gym, or listening to music, or maybe taking a walk, phoning a friend, if that is how you cope, well, that is considered a positive coping mechanism. However, if you drink or take a substance and that is your coping mechanism, smoke a cigarette, um, vape, whatever your coping mechanism is, that may be considered a negative. So, but the body is going to want what the body is going to want. So, in using this coping mechanism, it sometimes may cause the patient to quote unquote relapse. And again, we should not see relapse as a failure. It just means that we need to do something else in order to assist this patient. So, the complications that are associated with chronic use of cocaine are varied, and virtually every organ system being affected by chronic cocaine use because of vasoconstriction and neural death that is going to occur. This is incredibly, incredibly harmful and toxic to the individual. Cocaine abuse has been associated with cardiovascular issues such as hypertension, tachycardia, and arrhythmias, pulmonary issues, neurological issues, infectious diseases, gastrointestinal disorders, hematological and obstetrical complications, as well as homeostatic disturbances. So, MDMA. MDMA is usually taken orally as a capsule or a tablet, and this will produce feelings of emotional warmth, that warm and fuzzy feeling, euphoria, and then increased energy, along with distortions in time, perception, and then tactile experiences. So, as opposed to dopamine and all of the things that we have been talking about so far previous to MDMA, have dealt with dopamine. So MDMA is now dealing with serotonin. So serotonin is the neurotransmitter that is primarily affected by MDMA. MDMA will also influence the neurotransmitter norepinephrine, which can cause an increase in blood pressure and pulse. Like other drugs of abuse, MDMA can be dangerous to overall health, and it can also be lethal at times. So, the increased blood pressure and pulse that is caused by MDMA will increase the cardiovascular risk. In high doses, MDMA can interfere with the body's ability to regulate temperature, which can lead to a sharp increase in hyperthermia and then result in liver, kidney, and cardiovascular system failure or the death. So, medical management, screening, and interventions. Relapse. Remember, ladies and gentlemen, please, relapse does not signal failure. It indicates that treatment needs to be reinstated or adjusted, or that alternative treatment is needed to help the individual regain control and then recover. To be effective, treatment does not need to be voluntary. Just like the patient that shows up in the ER bed, it doesn't matter how they got there. It doesn't matter whether they walked in on their own, a family member brings them in, they come in as a result of a medical emergency or a motor vehicle accident. It doesn't matter. They're there now. So let's deal with this now. So, in the same respect, treatment does not need to be voluntary. Sanctions or support from the family, from an employer, or from the criminal justice system can increase treatment entry, retention rates, and then the ultimate success of the drug treatment intervention. Meaning that once the patient goes through detoxification and they realize, wow, look at what I've done, look at what I've lost, look at what this habit is costing me, maybe they get some sort of wake up moment, a come to Jesus moment, and then they have a very good success in their rehab recovery. However, Some people do relapse. Yes, I understand. But again, it doesn't matter how they get to treatment, but please remember, treatment does not need to be voluntary. Sometimes people need that extra incentive, that extra push. So, emergency departments, trauma centers, primary health clinics, and then other community healthcare venues will provide opportunities for early intervention with at risk substance users before more serious consequences can occur. So, screening will assess the severity of substance use and identify the appropriate level of treatment. So, I am having a conversation with someone. Maybe it's a student, maybe it's a student at a college campus, maybe I'm doing a talk somewhere or an educational session somewhere, and someone comes up to me and says, "Hey, listen, what do you think about this?" I can very quickly ask them some screening questions, and then maybe not exactly make a recommendation, but maybe make a suggestion, such as, you know, it really does look like this may be a problem for you. You might want to go and talk to somebody. You might want to seek out some treatment. So the individuals deemed to be at risk will receive a brief intervention that will focus on raising their awareness of substance abuse, and this may motivate them to change some of their behaviors. So, nursing management. The cornerstone of assessments for substance abuse problems is establishing a rapport. It has to be a trusting relationship and taking a thorough history from the patient and from outside informants, family members, friends, other healthcare providers, anybody that can offer any information about this individual or this individual's past history. And then the nurse must communicate to the patient that there is no judgment. There can be no judgment. It needs to be a very trusting relationship. So the patient needs to understand that their information will be kept confidential and that the nurse is simply there to help. I have no judgment. It doesn't matter to me what you did. It doesn't matter to me how you got here. My job is to simply help you and support you. So, in looking at the care plan, one of the things that we have to look at in this plan of care are nursing diagnoses and the problem list. So, let's think about some of these things. Alteration in comfort, which is physical pain or discomfort that is related to cravings or withdrawal from the substance. Sensory perception alteration that is related to withdrawal from the substance. Risk for injury related to withdrawal from the substance. Alteration in their nutritional status, less than body requirements related to poor dietary intake secondary to drug or alcohol use, and decreased appetite with accompanying nausea and vomiting secondary to the withdrawal. Sleep pattern disturbance related to withdrawal from the substance. Anxiety that is related to the distress of the withdrawal, and then the absence of their usual coping mechanism. Hopelessness that is related to the chronic nature of the disease, and maybe they have tried to recover in the past. So there is that possible past failed attempt at recovery. And then always in the plan of care is knowledge deficit related to the withdrawal process and treatment recovery planning, and then relapse prevention. So, nursing interventions, we are going to assess because we are nurses. We are going to assess, and we always start with vital signs. We are going to look at vital signs for an increased pulse rate, increased blood pressure, and temperature, as these may be signs of autonomic hyperactivity and indicate withdrawal. Vital signs are a useful index in the severity of substance withdrawal. So, frequent monitoring is required to ensure safety, treat their withdrawal symptoms, and then promote comfort. And then we will look at the mental status of this patient. Withdrawal symptoms may be unpredictable. So changes from their baseline may indicate increased severity or withdrawal or other physiological or psychiatric problems. Prompt response will reduce the risk or worsening clinical manifestations. Comorbidity, psychiatric problems are common in persons who abuse substances because they want to self-medicate. So patients withdrawing from substances may have impaired reality. We can also take a look at that CBC, the complete blood count. Decreased hemoglobin and hematocrit may reflect such problems as iron deficiency anemia or acute chronic gastrointestinal bleeding that is associated with chronic alcohol use. The white blood cell count may be increased with infections associated with drug and alcohol use. We are going to look and monitor their glucose levels. Hyperglycemia, hypoglycemia may be present related to pancreatitis, malnutrition, or depletion of liver glycogen stores that are associated with drug and or alcohol use. And we will always look at serum electrolytes. Hypokalemia and hypomagnesemia, are common with AUDs. And we will do a comprehensive medical, psychiatric, substance use abuse history, and then the physical exam. So, establishing an appropriate diagnosis and determining if acute intoxication overdose is present are essential in determining the appropriate treatment. To prevent AWS in hospitalized patients, nurses need to assess the pattern of their alcohol abuse. So again, comes that trusting relationship, that confidentiality that says, if the patient tells me they are actually drinking how much, that is only how I can help them. Medical and psychiatric problems that may have been masked by substance use may reappear or appear for the first time. So, nursing actions and medications, methadone. Methadone will bind with the opioid receptors with a controlled release effect that will greatly reduce the addiction risk while reducing withdrawal symptoms and then drug cravings. Sublocade. This will provide less risk for overdose, fewer withdrawal effects when stopped, and a lower level of dependence than with methadone. And then Narcan. Narcan will prevent substance users from feeling the effects of the drug. It is also used to reverse the respiratory depression that is seen with acute overdose. So, nursing actions in AUD treatment. So, antabuse will work by causing a severe adverse reaction, nausea, and vomiting when a person taking the drug drinks alcohol. Revia, naltrexone, will block the high that people experience when they drink or take drugs such as heroin or cocaine. And then Camprol, this medication will reduce the physical distress and emotional discomfort people experience when they quit drinking, either on their own or under supervision. So, ladies and gentlemen, please know these medications. So, more nursing actions. We will maintain a calm environment with appropriate lighting. Excessive stimulation may exacerbate the effects of withdrawal. We are going to establish a rapport by using a non-judgmental, caring, and competent approach because remember, this is a disease process after all. This will build trust and minimize resistance. We will demonstrate acceptance of the patient as a worthy human being and one that is deserving of care. And we will provide psychological support and instill hope that successful recovery is possible. So, ladies and gentlemen, thank you again for your time and attention to this very sensitive and occasionally emotional topic. You will notice that during this this mini lecture, I did not refer to any tables. I didn't refer to any boxes. I didn't refer to any safety alerts. So, because of this, I will refer you to the blueprint that is already posted. Thank you again.